Welcome, medical and nursing students, to this explainer. Today, we're exploring a massive, yet often entirely unseen threat to systemic balance: arterial hypertension. As future healthcare professionals, we're going to encounter this condition literally every single day, no matter what specialty we end up in. It's a huge driver of global morbidity and mortality. But here's the catch: because it usually doesn't have immediate, visible symptoms, patients just overlook it until severe complications pop up. So our goal today is to really get a deep, actionable understanding of what's happening at the vascular level so we can jump in and intervene effectively.
Okay, here's a quick look at our agenda for today. First, we'll be defining a high blood pressure. Then we'll dive into the risks of the silent killer. And finally, we'll wrap up with essential lifestyle management advice.
Section 1. Defining high blood pressure, the clinical parameters. So, we define primary or essential hypertension by some very specific thresholds. We're looking at a persistent elevation of systolic blood pressure at or above 140 millimeters of mercury or diastolic blood pressure at or above 90 millimeters of mercury. Now, it's absolutely crucial that we master the English terminology here: systolic and diastolic blood pressure. And honestly, here's a great practical pro tip right from the 2025 clinical guidelines. This isn't just about a single elevated reading. Nope. Diagnosis actually requires confirmation across at least 2 separate clinical visits, and they need to be measured under proper resting conditions.
Looking at the 2025 clinical guidelines, it's really fascinating to see just how precisely this condition is stratified. Notice how optimal is strictly under 120/80. But as soon as a patient hits 130/85, boom, they're in the high normal category. And that is a crucial window for early intervention. From there, we grade the hypertension from stage 1 all the way up to stage 3, which is 180/110 or higher. Getting this categorization right is the very first step in figuring out if a patient needs immediate pharmacological therapy or if we can start them off with lifestyle modifications.
Which brings us to a really critical clinical question. Why do we constantly refer to a condition that affects up to 30% of adults worldwide as the silent killer? Well, the answer lies in the massive gap between the physiological damage that's silently occurring inside the body and the fact that the patient subjectively feels completely fine.
Section 2. Risks of the silent killer: pathophysiology and organ damage. There is such a stark contrast between a healthy blood vessel and the pathogenic cascade we see in hypertension. In a healthy vascular system, the endothelial lining is fully functional, and those arterial walls are highly elastic. They easily expand and contract to smoothly manage blood flow. But with hypertension, it's a completely different story. That chronic high pressure leads directly to endothelial dysfunction. The blood vessels literally lose their elasticity, and that causes increased peripheral resistance and sustained arteriolar spasm. Basically, the body's renin-angiotensin-aldosterone system kicks into maximum overdrive, and it creates this vicious compounding cycle of more constriction and even higher pressure.
So here's the really crucial point. While the patient feels completely fine, maybe they just have a little fatigue or a mild headache, this sustained high-pressure system is silently inflicting severe target organ damage. In the heart, all that chronic extra workload leads straight to left ventricular hypertrophy. Down in the kidneys, the delicate filtration system gets damaged, which presents clinically as microalbuminuria and eventually chronic renal failure. Up in the brain, the risk of a stroke just skyrockets, and systemically, if you do an ultrasound, you'll often see intimal medial thickening of the blood vessels. We absolutely must be looking out for these secondary signs in our patients.
To really put the neurological risk into perspective for you, severe hypertension, meaning a systolic pressure that's consistently over 160 millimeters of mercury, increases a patient's risk of developing dementia by a staggering 4.8 times compared to someone with normal blood pressure. Almost 5 times. That is a massive and honestly often under-discussed consequence of failing to control blood pressure in mid to late life.
So what's actually happening there? Well, the mechanism behind this cognitive decline is driven by cerebral small vessel disease and the formation of white matter lesions. These are English clinical terms you absolutely must recognize when you're evaluating neuroimaging, like MRIs. Basically, the continuous high pressure damages the microvasculature of the brain. That leads to microhemorrhages and chronic localized ischemia. Over the years, this structural damage is exactly what manifests as executive dysfunction and memory loss.
Section 3. Essential lifestyle management advice: non-pharmacological interventions.
For a lot of our patients, especially those sitting in the high normal or stage 1 categories without any existing organ damage, we don't jump straight to medication. Before initiating pharmacology, our first line of defense rests entirely on 3 evidence-based, non-pharmacological interventions: dietary modification, aerobic exercise, and comprehensive weight and stress management.
The absolute cornerstone of dietary intervention is the DASH diet. That stands for Dietary Approaches to Stop Hypertension. It naturally lowers blood pressure by providing a really high intake of potassium, magnesium, and calcium alongside essential fiber. The whole emphasis is on deeply integrating fruits, vegetables, whole grains, and low-fat dairy into the patient's daily life, while significantly pulling back on processed foods and empty carbohydrates. Now remember, this isn't just a weight loss diet. It's a highly targeted metabolic intervention that actually improves insulin sensitivity and reduces lipid levels.
Clinically speaking, we have to be incredibly clear when instructing our patients about this exact balance. We need to tell them to increase their aerobic activity. Specifically, we're talking about 30 minutes of moderate activity, like brisk walking or cycling, 5 days a week, aiming for about 60 to 70% of their maximum heart rate. But at the exact same time, they absolutely must decrease their sodium intake to under 5 grams of salt a day, cut out saturated fats, and, very importantly, they need to avoid static physical loads. Things like heavy lifting or isometric exercises can actually acutely spike intrathoracic and arterial pressure, which is exactly what we don't want.
Now, this next fact honestly surprised me when I first read it. Simply guiding an overweight patient to achieve a 10-kilogram weight loss can independently drop their systolic blood pressure by 5 to 20 millimeters of mercury. Let that sink in. That is literally the equivalent of adding a full-dose, first-line antihypertensive medication purely through lifestyle modification. It highlights exactly why BMI and waist circumference are such vital metrics during our initial cardiovascular workups.
I want to draw your attention to a really powerful quote from the literature. It says, despite the wide availability of effective and inexpensive antihypertensive drugs, rates of hypertension control worldwide remain unacceptably low due to therapeutic inertia. Guys, as future clinicians, we have to combat this therapeutic inertia. The tools to diagnose and treat this condition are simple, they're inexpensive, and they're readily available everywhere. But patient compliance, rigorous monitoring, and our own willingness to aggressively adjust treatment plans, that is where the real battle against this disease is won.
So, I want to leave you with this final thought for your upcoming clinical rotations. Knowing the completely silent, destructive nature of arterial hypertension, how proactive will you be in recognizing and managing it? Are you going to settle for a single high reading and just dismiss it as white coat syndrome? Or will you use Holter monitoring, aggressively pursue lifestyle changes, and truly protect your patient's hearts, kidneys, and brains from the silent killer? Ultimately, the choice and the responsibility is entirely ours. Thank you so much for joining me on this explainer today. Keep studying and keep advocating for your patient's long-term health.